I will talk on important cervical spine disease, that is a degenerative cervical myelopathy. Degenerative cervical myelopathy is caused by dynamic or a static mechanical compression of the cervical spinal cord as a result of various degenerative or congenital pathologies. Consequently, vascular supply is altered and apoptosis of the oligodendrocytes and neurons occurs. That is, ischemia of the spinal cord occurs. The spinal canal of the cervical spine may be narrowed by a bulging disc or a bony osteophytes and or hypertrophy or calcification of ligaments. DCM remains the leading cause of cervical spinal cord dysfunction in adults with a rising prevalence due to an aging population. Clinical syndromes and pathogenesis of cervical myelopathy. Early clinical indicators of DCM are often absent. Patients usually present late. Subsequent disease progression may lead to gait and balance disturbances measured by the patient present in this stage. Worsening of the fine motor skills or diffuse numbness in the hands that leads to difficulty in holding objects and abnormal reflex findings. Depending on the degenerative extent and site of neurological compression, clinical symptoms such as radiculopathy can also occur. Mechanical compression of the spinal cord is widely held to be the primary pathophysiological mechanism of the cervical myelopathy. Animal studies have shown that at least 40% of the cord compression was necessary to produce reversible neurological deficits. Evaluation of the cervical myelopathy patient is very important. An evidence-based diagnostic algorithm in a patient with the clinical symptoms of a DCM includes in extensive evaluation of the patient history, examination, imaging including radiographs, magnetic resonance imaging MRI, and sometimes CT scan and electrodiagnostic studies. Both somatosensory evoked potentials and motor evoked potentials are essential. Coming to the treatment management, DCM and spinal canal stenosis with no clinical symptoms or electrophysiological findings should initially be treated conservatively, but routine re-evaluations are recommended. You have to follow the patient regularly. Additionally, a functional scoring system, the modified Japanese Orthopedic Association score, is helpful in determining appropriate treatment strategy. Based on a total normal score of 17, the MJOA scale sets mild DCM at 15 to 16, moderate DCM at 12 to 14, and severe DCM at less than 11. Efficacy and safety of surgical decompression in patients with a cervical spondylotic myelopathy. In cases of a moderate or severe symptoms of a myelopathy, surgery may be indicated because it halts disease progression, either directly or indirectly. The objective of surgery is to achieve spinal cord decompression. For this purpose, both anterior cervical discectomy and fusion carpectomy or a disc arthroplasty and a posterior laminoplasty or a laminectomy approaches may be used. The surgical strategy should be based on the source of and site of compression, and biplanar profile reconstruction considerations should be taken into account. Predictive factors for positive surgical outcomes are reasonable restoration of the spinal canal dimensions, earlier decompression, lack of comorbidity, and lack of intramedullary cord changes. In general, surgical decompression improves the disability and neurological function and health related quality of life.